In this particular section, we are going to deal on a very, very important topic, that is on chronic myeloid leukemia. So, what do you mean by a chronic myeloid leukemia? This image is what is the most important thing, that is this typical Philadelphia chromosome formation, that is translocation of 922, which is equal to translocation of BCR-ABL and its fusion. This is the landmark. I mean, one of the landmark discoveries in CML, and treatment is also directed against this only. So how come this can result in your chronic myeloid leukemia? For example, I told you any myeloproliferative disorder, you'll have a myeloid precursor cell, which is going to differentiate into granulocytic lineage, and typically they form this colony forming unit, granulocyte, from this granulocytic lineage. And they form a lot of other things also. This colony forming unit, granulocyte, is the one that is going to form the neutrophils. And similarly, you have this myeloid precursor which forms the erythrocytes also. The same myeloid precursor is going to form the megakaryocytes also. So all these are coming from a common myeloid progenitor. But remember, I'm not talking intentionally on, because there are this granulocytic lineage means they can form eosinophils and basophils also. I'm not going to talk about that. My area of concern here will be on the granulocyte forming the neutrophils. This colony forming unit G forming the neutrophils. Remember, there is something called an ABL kinase. We tend to call it something called ABL kinase. ABL kinase is there. So this ABL kinase activity is very important for this successful movement of this colony forming unit granulocyte to differentiate into neutrophils. And maybe the precursors of the neutrophils also, of which your ABL kinase is very, very important. But what happens in this CML is, because of this 922 fusion, you can see here, you have this chromosome number 9 and chromosome number 22. You have this ABL gene on chromosome number 9, and you have this BCR gene on chromosome number 22. So as a result of this fusion, you can see this ABL gene has jumped, and you result in something called an BCR-ABL fusion. The result is that this chromosome number 22 that contains this fused BCR-ABL gene, and this is what we are going to call it as something called a Philadelphia chromosome. Clear? The chromosome number 22 is the one that we'll call as Philadelphia chromosome. And one important thing what you can see is, see the size of the chromosome number 22 before fusion, and see the size of the chromosome number 22 after fusion, which means it's a little bit short compared to the original normal chromosome number 22. So that's why this is also referred to as something called a foreshortened chromosome number 22. So if they ask you what is Philadelphia chromosome, Philadelphia chromosome is a foreshortened chromosome number 22, where there will be a translocation of ABL gene towards the BCR gene that is present on chromosome number 22, so resulting in something called a BCR-ABL fusion. Remember, now normally this ABL produces something called an ABL kinase. Now what is going to happen is, now because the BCR-ABL fusion gene here, they will produce a new form of fusion protein called BCR-ABL fusion protein. This fusion gives a kick to this ABL kinase protein, which means they are going to have increased kinase activity. They are going to have increased kinase activity. Clear? So there are two types of BCR-ABL fusion transcripts are produced. One is the famous 210 kilodalton transcript, which is the most common, and this can be a 190 kilodalton transcript also. That is actually less common. If you ask me normally what is the size of this ABL kinase, normal size of this ABL kinase protein, that is only 145 kilodalton. So this is a normal ABL kinase. You can see now the new fused BCR-ABL kinase protein, because of the BCR-ABL fusion product, is going to have increased size. Doesn't mean always reflect increased activity, but in this case it is associated with increased kinase activity of this new fusion protein. Now I told you this ABL kinase is the one that helps in differentiating this CFUG towards the neutrophilic precursors and the neutrophils. So what is going to happen is now this is no longer an ABL kinase, no longer an ABL kinase. Now it's going to become a BCR-ABL fusion kinase. So this is a new kinase, and this is more aggressive than the ABL kinase, and this is going to stimulate more and more the CFEUG to differentiate into neutrophilic precursors in the neutrophils. The result, you are going to get a lot of excessive neutrophilic precursors and neutrophils. So this is the pathophysiology of your famous chronic myeloid leukemia. In this, the most important point where the examiner likes to ask is, what is the Philadelphia chromosome? It is chromosome number 22, which is foreshortened, and the fusion product is present on the chromosome number 22 only. Because the ABL gene is present on chromosome number 9 and BCR gene is present on chromosome number 22, the ABL moves towards the BCR and forms the fusion product. That new fusion product is having enhanced kinase activity, and that's the reason for this CML. Clear? Okay. Now what are the standard features of CML? Let us see the epidemiology first. If you ask me the epidemiology first, the median age is approximately around 65 years. That's where it is. It contributes around 10 to 15% of adult leukemias in general overall. Remember, the most common adult leukemia we've discussed already, it is CLL, lymphocytic leukemia, but this forms around approximately 15% of the adult leukemias overall. Remember, risk of CML is increased with your radiation, prior exposure to radiation, but there is no relationship with your anti-cancer drugs like alkylating agents or cytotoxic treatment. Remember, again I would like to tell one point, like AML has association with all these things, radiation, chemotherapy, all these things are associated with AML. But your CML is associated only with radiation but not associated with any drug or cytotoxic therapy. But your CLL is not at all associated with radiation also. No radiation association, no drug association or any toxin association, there is nothing with CLL. AML has all these things, CML has only radiation relationship, CLL has no relationship with any of these things. Very important point once again. Okay, how can we classify the disease? Let us see how we are going to classify the disease. Classifying disease classification means there are three classic phases. The first one we are going to call something called chronic phase, and the second one we are going to call something called accelerated phase. Accelerated phase always referred to as AP, and the third one we have something called a blastic phase. Blastic phase. Typically, most common transformation of CML, evolution of CML is from chronic phase to accelerated phase and accelerated to blastic phase, and this kind of transformation happens in 85% of the patient, which means this is classic triphasic evolution of CML. So this is how almost 85% of the cases present as well as move in their clinical course. But there are some rare cases who can present straight away with accelerated phase or who can straight away present with blastic phase also. But 85% of the times, its evolution will be like starting from a chronic phase towards the accelerated phase and ends with the blastic phase. If you don't treat them, most often they die at that phase. Okay, what do you mean by chronic phase? Chronic phase means depending on how many blasts are there in the bone marrow. If you ask me the amount of blasts in chronic phase, it's going to be less than 10% blasts in the bone marrow. That is very, very important. We are talking about the bone marrow blasts or in the periphery. So in accelerated phase, the amount of bone marrow is going to be somewhere around 10 to 19%. Obviously in blastic phase, they become like acute leukemia, which means the blasts are going to increase more than 20%. Remember, acute leukemia's blast will be more than 20%. If you tell a chronic leukemia, there should not be that much blast. It should be less than 20% by definition. So more than 20% blast will be there. Along with that, you will have a lot of associated findings. Typically, your basophils will start increasing. Here, there is no much assayed finding here. Everything will be quiescent here. Silently here, your basophils will start increasing in the peripheral smear, typically by more than 20%, and platelets will start dropping. Remember, in CML in chronic phase, the platelets tends to be high, which I will tell you separately. Thrombocytosis is actually quite common. But here, in accelerated phase, the platelets will start reducing to less than 1 lakh, less than 100,000 or less than 1 lakh. The thrombocytopenia starts. evolving. And many of the times you can see the clonal evolution. I told you one of the important feature of any malignancy is evolution. Just keep accumulating mutations and new mutations also starting to come, and you can very clearly see this clonal evolution, which means there will be some mutations which are not seen at diagnosis. That's a very important thing actually according to WHO diagnose accelerated phase as well. So there will be clonal evolution, which means there are going to be new changes, new karyotypic changes that not be seen at diagnosis. And in the bone marrow you can also see certain megakaryocyte proliferation and fibrosis. You can also go for megakaryocyte proliferation and fibrosis, and this is also possible. That is the reason in last topic, in the last part of the myeloproliferative neoplasm lecture, I would have told in primary myelofibrosis I have given CML as one of the important things, because CML during accelerated phase may end up with the myelofibrosis. That is why. That is due to excessive megakaryocyte proliferation releasing excessive PDGF. Whenever you have bone marrow fibrosis, somewhere megakaryocyte will have a role. I told you this already. So these are the things that you will see in the accelerated phase. And what about the blastic phase? In the blastic phase, typically you are going to see more than 20% of the blasts in the bone marrow. At the same time, what will be the type of blast if they ask you? Around 2/3 will be myeloid blasts, that is going to be very common. 1/3 may even show lymphoid blasts. They even go for lymphoid maturation. So even they can have lymphoid blast also. Clear? So this is very important, but the most common blastic stage is myeloid blast. That is actually quite common compared to your lymphoid blast, which is seen only in 1/3 of the patients. And next thing, if you ask me, most of the patients in chronic phase will not have any symptoms. For example, most of the patients in chronic phase will be completely asymptomatic except for the splenomegaly. Many times it could be moderate to massive splenomegaly. Most of the time will have usually asymptomatic. Only thing they will be having is splenomegaly, and the problem is maybe due to splenomegaly they might have some problem, because the splenomegaly is a very important finding in CML, because many times that might be the only finding in CML. That's why it's very important. At the same time, patient may have constitutional symptoms. Remember, whenever the CML is crossing phases from one phase to another, for example, a chronic phase become an accelerated phase, or accelerated become blastic phase, this transmission to other phases usually will have worsening of the clinical features. Like patient will get more and more constitutional symptoms, patient may get more fatigue, patient start getting fever, and patient may even start bleeding because of thrombocytopenia, even though it not be that severe, and infection rates are very high. So when the patient moves from one phase to another, your symptoms will start increasing. That's also very important. But typically CML in chronic phase, where they commonly present, will not have any symptoms most of the time. Only thing they will be having is splenomegaly. That's why finding of the splenomegaly in CML is of paramount importance. Abdominal examination is really important. Pain may be due to spleen, the chronic dragging pain may be there because spleen, and patient might themselves tell there is a mass in my left hypochondrium. They might feel that because the spleen gets enlarged so much. Or very rarely they might have mild constitutional symptoms in chronic phase. Apart from that, they don't have any much problem. Clear? Okay, fine. So apart from that, how will you do the diagnosis in case of a CML? Diagnosis is quite simple. So the moment I am going to diagnose CML, I'm going to do find out that karyotyping, and I'm going to find out that cytogenetic change, that is BCR-ABL translocation. That's the most important to find out. But anyways, let us start from the peripheral smear first. In the peripheral smear, what I am going to see is typically leukocytosis. That is what the most important finding. Leukocytosis is the most important finding according to the peripheral smear. And in the leukocytosis, it will be typically left shifted, plus there will be good myeloid maturation. And this myeloid maturation will be present in all stages. At all stages of myeloid maturation. Do you understand? So this is, I'm talking about the chronic phase. I'm not talking about the blastic phase or accelerated phase. In the chronic phase, this left shift is important. At the same time, myeloid maturation should be seen at all stages, which means you will see a promyelocyte, you will see a metamyelocyte, you will see a band form, you will see a mature neutrophil, you will see all stage of myeloid maturation, and granulocyte maturation will be seen. Very important point. Because if you don't see this maturation sufficiently, and majority of them are blasts, it goes towards more of a blastic phase or an acute leukemia. So in chronic phase, you should not see typically more of the blast. It should be more of a maturation of all the subsequent cells, whatever you see in the lineage. So this is very important point. At the same time, patient may have basophilia. This basophilia, even though wherever it is important, I don't know, but in CML it's really, really important. Many times whenever they give basophilia in exam, it always almost goes towards the CML. I don't know. That's how because even though there are other causes are also there. Then the patient will have thrombocytosis. That's why I told you thrombocytosis usually goes towards a chronic phase, whereas the onset of thrombocytopenia may indicate the patient is going for a accelerated phase. Very important point again. And the patient may have anemia as well. So all these are because I told you already, you can see here majority of the myeloid precursors is actually pushed towards forming a granulocyte and neutrophilic lineage. That is why your erythrocytic lineage is actually deprived and the bone marrow is completely filled of what? Your granulocyte and its precursors. That is the reason there is less room for producing your erythrocyte precursors. That is the reason why you get an anemia. At the same time, megakaryocyte proliferation is a common feature of CML as well. That's the reason they go for this myelofibrosis also in later stages. That's the reason why they have thrombocytosis but not thrombocytopenia, but later stage they'll go for thrombocytopenia. Clear? So all these things are typical features of a chronic phase. Apart from that, I'm going to see the bone marrow. How is going to be the bone marrow finding? Bone marrow is typically hypercellular and there is definitely increased myeloid erythroid ratio will be increased. Normal is around 3:1 I told you. Here it may be 10:1 or even 20:1 sometimes. So there will be very highly elevated myeloid erythroid ratio. Remember, from the cells what you obtain, you have to definitely do karyotyping. Karyotyping, typically it's done from the bone marrow, even though you can do from the peripheral smear, but if you do from the bone marrow only, you will get a high yield in karyotyping. So once you do the karyotyping, you can classically see that Philadelphia chromosome. You can see the Philadelphia chromosome transcript here, the typical BCR-ABL fusion, and it's very easy to find out. That's the reason I told you in karyotype, by looking itself you can find it's a foreshortened chromosome number 22. So that's what we call Philadelphia chromosome. It will be shorter than usual. That itself will tell you clearly in exam that it's a Philadelphia chromosome. So that's what you're going to do in the bone marrow. So let us see the image here. What you are seeing is, this is a peripheral smear of a patient from a CML. You are typically seeing a left shift. Where you are seeing is, you are seeing a lot of neutrophils and its precursors. You can see these are immature neutrophils. Let me put the immature neutrophils in pink. These are mature neutrophils I put in black, and you can see a lot of band forms. This is the band form, and this is a promyelocyte, and you can see this is a metamyelocyte, and this is actually a myelocyte. You can see a myelocyte, promyelocyte, and a metamyelocyte also, and you can see a band form. This is another band form. This is another band form, and this is one mature neutrophil you are seeing, little bit in between band and mature form. So you are seeing increase in the number of neutrophil precursors, but with all stages of maturation. You are not only seeing a blast. Are you seeing a blast? Yes, this is likely to be a blast. This too may be a blast, likely to be a blast, but apart from that, it's not that much. So you are seeing maturation in all stages. So this is what is typical of a CML. This is a typical peripheral smear of a CML. And probably, I think you can see thrombocytosis also to an extent. I think not much. You can see these are platelets actually. You can see to an extent, you can see a lot of platelets. May or may not be thrombocytosis, but still, this is a typical CML peripheral smear. And this is the karyotyping, where you can see this foreshortened chromosome number 22, and it will be a lengthened chromosome 9. So this foreshortened chromosome number 22 is what we refer to as something called a Philadelphia chromosome, PH+. So this is very, very typical, and this is a very important karyotype for exams also. Clear? I mean, obviously these arrows, I don't know whether they will give in exams or not, but anyway, this is a very important thing to understand. Okay, fine. So we have seen all these things, and next move on to the treatment of CML, because I don't think the diagnosis and morphology, clinical features and all in CML will take a lot of time, but treatment is definitely going to take a lot of time because of the advances in the treatment that we have right now in our practice. The characteristic first line and the most important treatment is TKA. Remember, this tyrosine kinase inhibitors have been discovered in the late 1990s, probably 1998, 1999. That's the time where imatinib first came, which is a prototypical drug that revolutionized the treatment of CML because it's a targeted therapy. Remember, other myeloproliferative neoplasms we have been treating with hydroxyurea, which is a non-target therapy. Initially, even CML, the treatment was hydroxyurea only because they thought all myeloproliferative neoplasms can be treated with hydroxyurea. It's a non-selective treatment and a non-targeted therapy. But once we started understanding what is the exact problem, once we started understanding that what is the exact problem, that exact problem in CML is your BCR-ABL kinase, fusion protein, that is a tyrosine kinase. And that is the reason why you get all these problems. We started developing drugs that target this BCR-ABL fusion kinase. So which means these tyrosine kinases are designed in such a way to inhibit the BCR-ABL kinase protein, so that your differentiation will reduce and your bone marrow output of the granulocytes also and the precursors also will reduce, so that you can effectively treat the CML. That's the idea. But anyways, this BCR-ABL kinase inhibitors, like this tyrosine kinase inhibitors, what I'm going to tell, is not only effective for your CML, it's also effective for inhibiting many other tyrosine kinase also, which I'm not going to tell right now. Let me tell the importance in some time. So let us see the diagram of how they are going to work. Number one, this is the BCR-ABL fusion kinase. You can clearly see this is not a original ABL kinase, which is a normal protein, but it's a BCR-ABL fusion kinase protein. Here what you are seeing essentially is this is the ATP binding site. You can see here. So this region is the ATP binding site of the protein. And you can see this is the catalytic domain. This is the catalytic domain, and you can see this one we call it as A loop, and this one typically we tend to call it as something called a P loop. So you have a lot of areas are there. So these are the four principal components of a BCR-ABL kinase fusion protein. That is your A loop, P loop, ATP binding site, and the catalytic domain where the substrate is catalyzed. You can see once the ATP, it's a kinase, so obviously it's going to phosphorylate this substrate. Once it binds with the ATP, because the kinase it has to work with the ATP. So once it binds with the ATP, it phosphorylates the tyrosine residues of this particular substrate. So that's why it's a tyrosine kinase. So what your drug is going to do is imatinib, or any other your tyrosine kinase inhibitors for that matters. They are going to bind with this ATP binding site. That's a very important point, maybe a very important question also. So this are going to target the ATP binding site. In this example I have given imatinib, so that your substrate cannot be phosphorylated. The tyrosine residues of the substrate cannot be phosphorylated, so that this BCR-ABL protein is inhibited. And because it's inhibited, it has no function, it will be destroyed and tagged for destruction later time, and BCR-ABL transcript level will decrease in the cell because of the inhibition, because it's no longer useful and no longer functional, means it will be destroyed by the cell. That's the idea. So that is how you treat a chronic myelogenous leukemia. So you are going to have a revolution after this development of this tyrosine kinase inhibitor, which is absolute gold standard for the current CML treatment. If they ask you first line, if they ask you gold standard, the answer must be tyrosine kinase inhibitors only, imatinib. This is the absolute gold standard because it changed the life of a CML patient in many, many good ways. That's why. Okay, fine. So even now, in my practice, we use this because this drug's name we call it as Gleevec. So that's a brand name that we use. Many of my patients are getting absolute benefit out of this Gleevec, imatinib, gold standard, absolute gold, first line. Definitely, there's no doubt about that. This has completely transformed the life of a CML patient and increased the survival rates like anything in the last 2 decades. Okay, the first line or first generation TKAs, that's what I'm going to tell. First generation, let us remove the name first line and we will put first generation TKA. The only first generation TKA that we have is imatinib, and still remains the gold standard, as I told you, and still remains the first line even after 20 years after discovery. So first thing, you have to know the side effects of imatinib. I mean, obviously, it does have some side effects. Side effects of imatinib are nausea, vomiting, diarrhea, muscle cramps. It can itself cause cytopenias. Even I've seen cases in neutropenia, really. And you can get hypophosphatemia. You can get QT prolongation. You can get congestive cardiac failure also. Plus, please, examiner's favorite will be this QT prolongation only. Clear? So that will be the only clinch point among all these things. Because I'll tell you, one drug does not cause QT prolongation. Bosutinib does not cause ICAS. I'll write in some time. So QT prolongation, absolutely important. Then you have the second generation TKAs that came. You can write simply as 2G TKAs, second generation tyrosine kinase inhibitors. These second generation tyrosine kinase inhibitors all have increased potency, all right, but have very high levels of toxicity also. Obviously, like something comes at the expense of something. So you should bear this toxicity, then only at the cost of its effectiveness and potency. So what are the second generation one? You have something called, 3 drugs are very important for exams. One is called nilotinib, and second one you have something called dasatinib, and third one you have something called bosutinib. Nilotinib, dasatinib and bosutinib. And you have certain side effects of nilotinib. Let us see the side effects of each and everything. Nilotinib itself has some side effects. For example, it can also cause QT prolongation. It can raise the bilirubin. It can raise the lipase levels, and it also has something called cardiovascular toxicity apart from raising the QT prolongation, apart from causing the QT prolongation. And dasatinib as such, it can produce effusions, both pleural and pericardial effusions, and it also can raise the QT. At the same time, it can also cause something called pulmonary hypertension. Clear? It can also cause something called pulmonary hypertension. And bosutinib as such, bosu means this is B-O-S-U. I mean, it looks like O here, that's why I'm telling B-O-S-U-T-N-I-B. Bosutinib's side effects are very simple. They are going to produce rash, diarrhea, and increase liver enzymes like OTPT, SGOT, SGPT. Transaminitis may be there. But remember, bosutinib is the only drug that does not have QT effects, QT prolongation. It does not cause QT prolongation. Very, very important point. That's why I told you. Among all the drugs, whatever we have seen, the bosutinib is one drug that does not cause QT prolongation. For example, in the future question, if they ask you all of the following can cause QT prolongation, except options will be imatinib, nilotinib, dasatinib, and bosutinib, your answer must be bosutinib. It does not cause QT prolongation compared to the other drugs, at least. So then there is something called resistance. There is something called resistance. So which means over time, I told you, all the cancers will go for something called clonal evolution. Clonal evolution, which means a new mutations might appear in the same protein or different proteins or same gene or a different gene. So that is what we call as clonal evolution. So because of clonal evolution of this particular leukemic cells or particular affected WBCs, what is going to happen is this BCR-ABL protein, it's a kinase, BCR-ABL kinase, also go for this clonal evolution, and they also go for mutations. They will also go for mutations. There are so many mutations are there. You can see mutations in the A loop, you can see mutations in the P loop, you can see mutations in the catalytic side, you can also see mutations in the ATP binding side. But I can put a tabular column telling all the mutations in one page, fine, that doesn't define anything because that is not useful anyways. Even the hematologist doesn't remember all the mutations. But the most important mutation, but anyone has to remember, is the T315I mutation. This mutation is the only mutation you have to remember. This is T359 mutation, very, very important mutation as far as CML is concerned, because this is regarded as one of the deadly mutations. And where it's going to happen? It's going to happen in the locking site of the drug, that is in the ATP binding site. Remember, like many other mutations are there in the ATP binding site itself. I'm not telling this is the only mutations in the ATP binding site. A lot of other mutations also, I think 3-4 other mutations are also there, but none is specific or none is as significant as your T315I mutations. This is a very, very, very important mutation. Clear? So remember why this mutation is very, very deadly, because none of the TKs will be effective. No TKs are effective for this mutation. Once this mutation comes, no TKs are effective. No TKs are going to be effective for this T315I mutations. But except one important TK is there, that is called ponatinib. Ponatinib is the only drug, if you ask me, among all the drugs, whatever, there is other drugs which I'm going to tell like oxytocin and all, but anyway, that is also effective for T315I, but it's not effective like ponatinib. Ponatinib is going to be the most effective drug for T315I. Most effective drug for this T315I mutations. Clear, definite question. No, like this should be the answer. Even though there are other drugs that can be effective, doesn't matter. This is the only drug that's the most effective for T315I mutation. And there are certain side effects of ponatinib as well. Like for example, you might get pancreatitis. You might get pancreatitis with ponatinib and increased risk of thrombotic complications. Very high risk of thrombotic complications. Suppose if they ask you, what are the other drugs that can be effective? I told you the only TK that is effective for this T315 is ponatinib. No other TKs are effective. But there are some other drugs which show marginal efficacy. Other drugs that show marginal efficacy for T315I mutations. So for example, drugs like oxytocin, meposuccinate is there. So I'll stick on to that's called oxytocin meposuccinate. So, but I'll stick on to the term called oxytocin. And probably there is a new drug called asciminib, but this drug is still in trials. Asciminib. I mean, this shows a lot of promise, but still in trials, so you can't answer in exam. So remember, the only drug again that is highly effective in T315 mutations is ponatinib. Again and again and again. Oxytocin is effective, but it's not that much effective. It's only for a shorter run. It's not effective for a long run. Very, very short run. Only a short-term response you can expect. So suppose there is a lot of difference. Whenever in exam they tell CML resistant disease, CML is showing some resistance, it's a resistant disease. Next step, always see whether it's a T315 mutation or not. This is a very important thing. The moment in exam, if they tell CML is showing resistance to imatinib, resistance means I'm talking about imatinib resistance. Resistance to imatinib. So see T315 mutations there or not? Yes or no? If no, it's not a T315 mutation, other second generation TKs you can use, no problem. You can use other second generation TKs, but if it's a T315 mutation, obviously you have to go for only one drug, that is ponatinib. Please don't choose drugs like oxytocin and all, even if it is effective. But on the other hand, if there is a question like all of the following drugs are effective for T315I mutation, except if the question, the answer states, if the option state ponatinib, oxytocin, asciminib, and maybe bosutinib, your answer must be bosutinib, because other three are at least effective to an extent. But the best effective, again proved, is ponatinib only. Clear? So this is very important thing to understand. Remember, and what about that? Your TKs. TKs are absolutely contraindicated in pregnancy. In pregnancy, you should not use this TK because TKs are contraindicated. You cannot use. Remember, even hydroxyurea for that matters are contraindicated. In pregnancy, you can use only interferon alpha, even in this CML patients. But to be honest, TKs cannot be given in pregnancy. Very important point. You can't give. Even hydroxyurea can't be given in pregnancy. Only interferon alpha can be given. So when you start with your imatinib, for example, or any other TKA for that matter, tyrosine kinase inhibitors, what is the assessment? Because you need to assess the disease activity and response to your drug, what you are giving. So remember, this is one of the landmarks in like hematology, CML treatment, and that's why it's very important to know each and every nook and corner of the CML. That's why I'm discussing everything. Definition wise, you have to know a lot of definitions because these are something called milestones are there. This is what we refer to as CML milestones. We assess at 3 months, 6 months and 12 months. Very important thing. I don't know how to tell all these things. So what you can tell is, let us see the definitions first. There is definitions for something called a complete hematological response. Stay with me carefully, even though this might look a little bit boring, but this is very important definitions. Complete hematological response. Then you have something called a cytogenetic response. if any institute question wants to screw you up, this will be the question. I'm telling you, it's very difficult to remember as well. There's no mnemonic or no magic for me, just I'm simplifying it and giving to you, that's it. So cytogenetic response, then you have something called a molecular response. You have something called a molecular response. Remember, complete hematological response you can see in the peripheral smear, and probably like bone marrow may be done, and peripheral smear itself is enough for me, differential TC-DC. And cytogenetic response typically is done along with using FISH, and molecular response I'm going to do with real-time PCR, RT-PCR. So you have to know about this as well. So what are the features of a complete hematological response? Complete hematological response, let us put in different colors to avoid confusion. Complete hematological response, number one, your thrombocytosis should resolve, which means in a chronic phase of CML, definitely there will be thrombocytosis, no doubt about that. So platelet count should come back to less than 4.5 lakhs per microliter or whatever it is, so number one. Number two, your WBC count should come to normal range, that is less than 10,000, usually it will be the 20 to 40,000 range somewhere around in CML. And third thing, spleen should become normal in size, very important point again. And number four, you should have a normal differential count in which especially basophil should become less than 5%. I told you basophilia is one of the important events that are happening in CML. I told you many times. So basophil should become less than 5% in CML. So this is what we refer to as something called a complete hematological response. So let us see what is the definitions of complete cytogenetic response. We'll put pink for this. Cytogenetic response by FISH. So if there is a no response, then we are going to see the Philadelphia chromosome transcripts during FISH and karyotyping. If Philadelphia chromosome transcripts are still more than 25% of the cells, if you are seeing this, then it's no response, zero response. You have something called a minimal response, where Philadelphia chromosome transcript levels is 66 to 95%. Then you can have something called a minor response, where the Philadelphia chromosome levels will be 36 to 65%. Then you have something called a partial response, where Philadelphia chromosome levels are 1 to 35%, and you have something called a complete cytogenetic response. The CCOR is very important terminology to know. That's called a complete cytogenetic response. So where the Philadelphia chromosome levels will be less than 1%, which means it's equal to 0%. There's no Philadelphia chromosome seen in any of the cells that you do for FISH. Clear? So then let us put green for this. What is the definition of a molecular response through RT-PCR? We are going to see the BCR-ABL transcripts here. You are going to see the BCR-ABL transcripts here. Amount of BCR-ABL transcripts through PCR. In the peripheral smear itself you can do again. Where you have something called two responses. One is called a major molecular response, that is referred to as something called MMOR, that's called major molecular response, where the BCR-ABL transcripts will be less than 0.1%, which is also referred to as something called more than 3 log reduction from the baseline. Then you have something called a complete molecular response. If you ask me a complete molecular response, here it will be completely 0% BCR-ABL transcripts, which means it should be completely undetectable BCR-ABL transcripts, or at least a more than 4.5 log reduction of BCR-ABL transcripts compared to the baseline. So these are the definitions. I don't know how much they will be asking, but I really feel this is really important to know. These are some of the something that is very basic in CML treatment and hematology, one of the landmarks and milestones in CML. And what are the milestones you have to achieve in CML? So which means I can tell something called an optimal milestone, optimal response, or otherwise referred to as an optimal milestone. This is what the real milestone you have to achieve. Clear? And second thing, what you are going to call it as a suboptimal response. Suboptimal response, and what you are going to call it as a failure of therapy. Failure of therapy, because based on this only you are going to plan further treatment. After you start imatinib or any other TKI, after this only, using this only you are going to plan further. Remember, if you ask about optimal response, I am going to see a 3 period. One is called 3 months, 6 months, and probably 12 months. 3 months, maybe you can write here 6 months, and maybe at 12 months. So what is the differences between optimal, suboptimal and failure? Optimal response at 3 months, which means it's a milestone that you have to achieve at 3 months. That's the target that we are planning to do by starting with the tyrosine kinase inhibitor. So at 3 months, you have to achieve a BCR-ABL transcript ratio of BCR-ABL transcript of less than 10%. It's not a complete, it's not a major molecular response, but at least a less than major molecular response. By definition, it should be at least less than 10%, or at least it should be more than 1 log reduction. 1 log reduction from the baseline. Remember, that is different. I will tell you when you will achieve a major molecular response. Similarly, this is one of the important thing. And at 6 months time, you have to achieve a BCR-ABL transcript ratio. BCR-ABL transcript ratio of less than 1%, or you have to, that is what we refer to as something called a more than 3 log reduction. 2 log reduction, sorry, less than 1%, and this is what we refer to as 2 log reduction, or if there is, should be a Philadelphia chromosome of less than 35%, which means you should achieve at least a partial response. Clear? So Philadelphia chromosome should be less than 35% in metaphase cells. And what about at 12 months? At 12 months, you have to achieve a complete cytogenetic response, which means there should be 0% Philadelphia chromosome, which means completely absent Philadelphia chromosome, and you have to achieve at least a major molecular response by 12 months. Major molecular response means that is at least less than 0.1% of BCR-ABL transcripts, or as I told you, it is at least more than 3 log reduction from the baseline. So it can be very simple. First 3 months is 1 log reduction, that is at least less than 10%. Then at 6 months it should be 2 log reduction, that is less than 1%, your BCR-ABL transcripts. At 12 months it should be a major molecular response, that is it should be less than 0.1% BCR-ABL transcripts or more than 3 log reduction. Okay, about Philadelphia chromosome, first we don't tell anything about the Philadelphia chromosome in the beginning. In the second 6 months, in 3 months we don't tell anything about the Philadelphia chromosome. In the 6 months mark, you should at least achieve at least a minimum of a partial response, that is less than 35% Philadelphia chromosome positivity in metaphase cells in fish. At 12 months it should be undetectable, 0%. There is no Philadelphia chromosome detectable at 12 months. These are the milestones that we are working towards by giving this tyrosine kinase inhibitors. And what do you mean by a suboptimal response? Suboptimal response at 3 months means anything less than complete hematological response, which means complete hematological response should be achieved immediately the moment you start imatinib. So anything less than complete hematological response, definitely it is suboptimal response. There is no doubt about that. And at 6 months, if the Philadelphia chromosome is still more than 35%, it means anything less than partial response. Anything less than partial, your partial is not achieved, anything less than your aim, anything less than your partial response aim is going to be a suboptimal response. And at 12 months, if the Philadelphia chromosome is more than 1%, Philadelphia more than 1%, or Philadelphia chromosome in the range of 1 to 35%. So this is what we refer to as suboptimal response at 12 months. What do you mean by treatment failure? Complete treatment failure. So if you have a no hematological response, which means absolutely no hematological response at 3 months, or if Philadelphia chromosome is more than 35% at 6 months, or still detectable Philadelphia chromosome. Detectable. Anything that is detectable Philadelphia chromosome itself, Philadelphia chromosome more than 35%, Philadelphia chromosome more than 35% is regarded as a failure. Clear? So, just what I am just trying to tell. So, Philadelphia chromosome more than 35% is a failure treatment. So, I have given a definitions for optimal response, suboptimal response, and a complete response. But I generally believe at least it's worth knowing this optimal response at least. That's why, that's what we are working towards, and that is the target for giving a tyrosine kinase inhibitor. It's really, really important. The targets are very important. Remember, 1 log reduction by 3 months, 2 log reduction by 6 months, and 3 log reduction of BCR-ABL transcript by 12 months. You can remember as first 10% and less, next is 1% and less, and finally 0.1% and less. 1 log, 2 log, and 3 log. Then Philadelphia chromosome, there is not much definition in the 3 months, and at 6 months it should be at least less than 35%, which means least minimum you should achieve a partial response, and at 12 months it is like a Philadelphia chromosome should be undetectable completely. It is complete cytogenetic response and major molecular response should be achieved by 12 months. And I think here also in flow I made a mistake. It is 95%. Clear? More than 95%. Whenever Philadelphia chromosome levels are more than 95%, it is definitely, failure treatment, which means there is no response or it's none. You can see here more than 95% means no response at 6 months, indicates a failure treatment. Okay. Along with this, there is something called anytime. For example, anytime after this, anytime after 12 months, anytime after the 12 months, you cannot give anything for optimal. Optimal you have to achieve by 12 months and after this it has to be maintained. But anytime after 12 months, if you have a loss of major molecular response, which means, what do you mean by loss of major molecular response? Once again the BCR ABL transcripts will become detectable and will become more than 0.1%. This is what we refer to as clinically something called molecular recurrence. If this comes, again it is defined as a suboptimal response. Or when you call a fail, when you have a detectable Philadelphia chromosome. When you have a detectable Philadelphia chromosome, which is what we refer to as something called a absence of complete cytogenic response. So absence of complete cytogenic response at any time indicates a failed treatment, and loss of major molecular response which you have already achieved at 12 months at any time after 12 months indicates a suboptimal response. And this is also one of the important definitions of optimal and suboptimal response. Clear? Suppose if it's going to be an optimal response, clear, or a failed response with imatinib. Suppose if the patient is already on imatinib and you are having a suboptimal response or a failed response, typically we'll see at 12 months, if it's still not working, you shift to a second generation TKI. Typically, this is what we do. Shift to a second generation TKI and check for T315I mutation. T315 mutation. As I told you, if T315 mutation is positive or T315 mutation is negative, if it's positive, we can continue with the, if it's negative, we can continue with the second generation TKI. If it is positive, you have to definitely shift to ponatinib. So still with second generation TKI or with ponatinib, if you are having a suboptimal or a failed response, you have to consider using something called allogenic hematopoietic stem cell transplant. This is the current practice what we do. Suppose if the patient is on imatinib, especially at 12 months is what we consider the most important. Even till 12 months you can wait to an extent. If 12 months, if you don't have a good response, either if you have a suboptimal response or a failed response, then you can shift to a second gen TKI and check for resistance mutations. It's going to take some time. So the result of the resistance mutations will come if T315I is positive or negative. T315 is positive, then I told you already, you have to shift to ponatinib. Or if T315I is negative, then you can continue the same second generation TKI, whatever you use, like nilotinib, dasatinib or bosutinib. So then if second TKI is also failed, it's also either ponatinib or any other second TKI is also not showing any response, or if it's showing a suboptimal response, it's better to consider using something called a allogenic hematopoietic stem cell transplant. So this is the flow chart on how to use your treatment for CML purposes. And finally, whether you can discontinue TKI or not. Can TKI be discontinued over time? Actually, yes, you can discontinue. But when? Yes means you have to answer this question also. When? If your complete molecular response, I'm not talking about a major molecular response. There's a difference between major molecular response and complete molecular response. Complete molecular response means undetectable BCR-ABL transcript. So which means it's a complete molecular response. Undetectable BCR-ABL, more than 4.5 log reduction. Complete molecular response is maintained for more than 2 years. Complete molecular response maintained for more than 2 years, you can discontinue the TKI, no problem, and wait. and observe the patient whether they are going for relapse or not. And what are the indications for allogenic stem cell transplant? Allogenic hematopoietic stem cell transplant. Remember, allogenic stem cell transplant can be considered as a first treatment. Those who have developed accelerated phase or a blastic phase. If the patient is going for accelerated phase or blastic phase, you can consider as an upfront hematopoietic stem cell transplant. Upfront means as a first line treatment. Immediately you can do HSCT. But if the patient has, it can also be considered in a patient who has already failed 2 TKAs. If there is a failure or suboptimal response with 2 tyrosine kinase inhibitors, in those patients also you can try. But I cannot call it as an upfront treatment over there because I am already treated with 2 TKAs. But if the patient is presenting with an accelerated phase or blastic phase for the first time itself, definitely I am going to use an upfront HSCT only, because the treatment there is different. Because in blastic phase I am going to treat like an AML or ALL. You can still use in accelerated phase your tyrosine kinase inhibitors to an extent, but for blastic phase and all, it doesn't work that much. I am going to use a chemotherapy that is similar to AML or ALL. So accelerated phase, yes, still I can continue with the tyrosine kinase inhibitor. That's also a very important point. But blastic phase, I don't think there is much role for TKAs. I'm going to treat like a ALL or AML. In these 2 conditions, if the patient is presenting with these features, it's better to straight away consider a upfront allogenic hematopoietic stem cell transplant. So let us see a brief overview of CML once again. Some few important points that you have to know. First thing, what you have to know, I'll just take 2 minutes of the time. So in CML, what is important is first is the classic BCR-ABL fusion. Where is BCR and where is ABL? BCR is located on chromosome number 22 and ABL is located on ABL kinase, we call it as, and that's located on the chromosome number 9. So this ABL from chromosome 9 gets translocated to your chromosome number 22, and a part of chromosome 22 also comes back to chromosome number 9. So the chromosome number 22 will be foreshortened, smaller in size, and there will be a new fusion product with BCR and ABL. This is what we call as BCR-ABL kinase fusion protein that's having excessive kinase activity. That's the problem in CML. And they produce 2 kinds of BCR-ABL kinase protein. The most common is the 210 kilodalton product, and second less common is the 190 kilodalton product, but the normal ABL kinase protein is 145 kilodalton product. Fine, this is the first thing that you have to know. Second thing, there are 3 phases. You have a chronic phase, you have an accelerated phase, and you have a blastic phase. Chronic phase, accelerated phase, blastic phase is the most common way of evolution of a patient who is not treated typically, or any point of time they'll go through these phases and they die in the blastic phase usually. So in the chronic phase, what will be the features? Blast less than 10%, accelerated phase 10 to 19%, and the accelerated phase 10 to 19%, and the blastic phase is going to be more than 20%, going to behave like an acute leukemia. Apart from that, in chronic phase, you are going to have a lot of other problems like splenomegaly, plus or minus patient will have thrombocytosis, plus or minus patient may have your basophilia, and all these things. And splenomegaly might be the cause of pain, but many times patient may be asymptomatic, coming only because of the mass in the left hypochondrium in the chronic phase. Some patients may be asymptomatic, or some patients may have mild constitutional symptoms. Whereas in accelerated phase, the patient's symptoms will start worsening. At the same time, patient will start developing new molecular changes and new changes in the karyotyping which you have not seen in the chronic phase. At the same time, they'll also start developing your thrombocytopenia and all these things. So this is again a very important thing, and the blast will start increasing 10 to 19%. In a blastic phase, it's more than 20%, and the patient is going to be heavily symptomatic, and they'll go for pancytopenia most of the time because of complete bone marrow infiltration with this leukemic blast. Okay, then what are you going to do? How are you going to treat this patient? Treatment, first line, imatinib, imatinib, and imatinib. And you have to see the response. The milestones are very important after giving imatinib. So once you give imatinib, where imatinib binds at the ATP binding site. So once you give imatinib, you see for the response, you assess the response over time. You have something called optimal response milestone, which is assessed at 3, 6, and 12 months. At the 3rd month, you should achieve a BCR-ABL transcript level of at least 1 log reduction, that is less than 10%. At the 6th month, 2 log reduction, at least less than 1%. At 12th month, at least 3 log reduction, that is less than 0.1%. Clear? So next thing, Philadelphia chromosome at 6 months must be less than 35%, at least a partial response. At 12 months, it should be undetectable, 0%. Clear? Full response. Philadelphia chromosome. That is what we refer to as a complete cytogenetic response. So two things are the targets at the end of 12 months. One is called a complete cytogenetic response. Second one is called a major molecular response. These two things should be achieved by the end of 12 years. So at the end of 12 months. So what do you mean by suboptimal response or treatment? At 12 months, if you don't have a complete cytogenetic response or you don't have a major molecular response, then definitely it is suggestive of a suboptimal treatment or a failure. In this condition, definitely you have to start a second generation TKA and you have to do the resistance mutation. So you wait for the resistance mutation to come. If the resistance mutation comes at T315I mutation, you go for the ponatinib. If the resistance mutation doesn't show 315I, then you can continue the same second generation TKA. Maybe slight tinkering can be done, but still same second generation TKA will be continued for most of the time if there is no T315 mutation. So either ponatinib or whatever you are continuing with, if it's still not showing optimal response or it's showing a failure, then there is no other option. You have to consider a allogenic hematopoietic stem cell transplant. Clear? So when you can stop the TKAs, if you have achieved a complete molecular response, that's why I called you, which means a BCI ABL transcript should be 0% and it's maintained for at least 2 years, then you can consider stopping the TKA and you can just wait for observation and you can watch the patient with a watchful observation. Clear? So this is what you're going to do for the CML. CML is very important, especially the landmarks are very important to know. So with this we can complete the CML and we can move on to the two other minor myeloproliferative neoplasm. The first one being the chronic neutrophilic leukemia. Chronic neutrophilic leukemia. So what is the problem in chronic neutrophilic leukemia? It is the CSF3R mutations. CSF3R mutations. There will be increase in the neutrophils, only neutrophils typically, other lesions will be normal, plus there will be no etiological cause of neutrophilia, which means you will not find any etiological cause. It's like hypereosinophilia only. A primary hypereosinophilic syndrome is sustained severe eosinophilia more than 1500 with no etiological causes. That's what I told you in the basics of WBC. Similarly, here no etiological causes for neutrophilia. Similarly, at the same time, there should not be any increased blasts or immature form. Increased blasts or immature form. Remember, if there are increased blasts and immature form, it will be called as a CML. If there are increased blasts only, then if it's more than 20%, it goes towards an acute leukemia. So be very careful. There will be no increase in the blast or no increase in the immature form. So how we are going to diagnose? So because the neutrophils are proliferating more, they suck out all the myeloid precursor cells towards neutrophilic differentiation. So they might have an associated anemia and a thrombocytopenia most of the times. But this generally happens in a late stage and the patient also will have a mild splenomegaly most of the times. And if you do a bone marrow examination, you can clearly see the myeloid erythroid ratio will be too much and often it goes up to 20:1. I told you normal it must be 3:1. In this condition it might go up to 20:1. So slowly, since this is a clonal disorder, I told you already, as all the malignancies, this is also a clonal disorder. So as all the clonal disorder, there will be clonal evolution and more mutations will start coming and eventually it transforms to AML within 1 year usually. AML within a year. They'll go for acute myelogenous leukemia and blastic phase will happen within a year most of the time. So prognosis variable, you can try giving probably hydroxyurea initially. When blastic phase means AML means you have to treat like that. Hydroxyurea will not work that time. Hydroxyurea you can use, or you can use interferon alpha in selected cases. Plus or minus you can go for allogenic hematopoietic stem cell transplant because of clonal stem cell. You cannot use an autologous stem cell transplant. You have to do an allogenic hematopoietic stem cell transplant. So then you have something called a chronic eosinophilic leukemia. Chronic eosinophilic leukemia. As I already told you, this is due to PDGFRA or it could be sometimes due to PDGF receptor B. And you will have rearrangements with something called FIP1L1. This I told you I think in hypereosinophilic syndrome also. This rearrangement happens in chromosome number 4. So PDGF receptor A and FIP1L1 translocations, chromosome number 4. So this will result in something called a chronic eosinophilia and there will be severe eosinophils more than 1500, which will be seen in the bone marrow as well as the peripheral smear. More than 1500 in the peripheral smear, plus you will see this eosinophilia in the bone marrow also. Clear? So typically blast may be seen, but it will be very less. Blast may be seen here, but it will be typically in the range of 5 to 20%, and these blasts are typically CD23, CD25 and 69 positivity. Very important again. So what is going to happen is these eosinophils are going to infiltrate multiple organs, infiltrate a lot of organs. Like for example, it can infiltrate the heart and can cause endomyocardial fibrosis, which can itself lead to something called restrictive cardiomyopathy. And it can infiltrate the lungs also, it can infiltrate the skin also, it can infiltrate the GIT causing bloody diarrhea also. It can produce anything. The same thing will happen in hypereosinophilic syndrome also. Multi-organ dysfunction and multi-organ infiltration by mature eosinophils. But what is the difference between your, like chronic hypereosinophilic syndrome? For example, you have something called a hypereosinophilic syndrome, and you have something called chronic eosinophilic leukemia. First, let us see the similar facts. So in both these conditions, your eosinophils will be more than 1500 in the peripheral smear. In both these conditions, you will have eosinophils more than 1500 in the peripheral smear. And there will be no etiology for eosinophilia. You cannot identify any etiology for eosinophilia in both. Yes, fine. And both will have multi-organ dysfunction, like heart, lung, like your GIT and bone marrow. A lot of areas may be infiltrated with this eosinophil. So both can have multi-organ dysfunction, doesn't matter. So what is the differentiating factor? Remember, the blasts are the ones that are differentiating factor. The blasts in chronic eosinophilic leukemia, as I told you, it will be in the range of 5 to 20%. More than 20 means it becomes an acute myeloid leukemia with eosinophilic differentiation. That is different. But here the blast will be less than 5%. Very important point. Similarly, can you show the clonality? Remember, hypereosinophilic syndrome is not a malignancy. Please understand, hypereosinophilic syndrome is not a malignancy. So clonality will be seen only in chronic eosinophilic leukemia, whereas in hypereosinophilic syndrome you cannot show the clonality. Very important. So you cannot show the CD markers, that's what I mean, in all the cells. That is called clonality. Clear? So this is how you differentiate between the hypereosinophilic syndrome and chronic eosinophilic leukemia. But there is another rearrangement, and let me finish off this one. So there is AML transformation can happen. There is not much risk like what you saw in chronic neutrophilic leukemia, but there is a small risk of transformation into AML is still there. And treatment is imatinib. That's why I told you imatinib can be used in many areas. Even in GIST we use imatinib, you know that. So, but imatinib can be used in many different areas. This is one of the areas where you can use imatinib. So, which will be effective for this rearrangement also. This PDGF receptor A and FIP1L1 translocation. This also imatinib will be helpful. But there is another translocation is there that is called PDGF receptor B and ETV fusion, ETV6 fusion. It results in something called a CMML with eosinophilia. CMML with eosinophilia. CMML I will tell you separately in overlap syndromes, but you can result in something called a CMML with eosinophilia. So usually how they present clinically is through, because of eosinophilia they will have skin manifestations and they are going to present with splenomegaly. And again remember, they will respond to imatinib. Clear? Please do remember, this PDGFR related mutations will still, rearrangements will still respond to imatinib. Very important point. So imatinib is also the treatment for CMML with eosinophilia. That is this PDGFR-B and ETV6 fusion. Then there is another entity called FGFR1 rearrangement. You'll have something called FGFR1 rearrangement is there. if you have an FGFR1 rearrangement, this is referred to as something called as stem cell syndrome. Stem cell syndrome. Typically, they present with B symptoms, splenomegaly, leukocytosis, lymphadenopathy, and probably weight loss. That comes under the B symptom. And this FGFR1 rearrangement will not respond to imatinib. Will not respond to imatinib. Only hematopoietic stem cell transplant can be done. Clear? Only hematopoietic stem cell transplant can be done. So, I mean, this could be a potential question. Remember, this FGFR1 rearrangement, I mean, usually called as 8p syndrome. Other name, I didn't tell you that. Other name is also called as something called 8p syndrome. Or is called as 8p stem cell syndrome because it's present in chromosome number 8. That's why. So the idea of telling this is because this chronic eosinophilic leukemia, many times you will confuse with hypereosinophilic syndrome, because in hypereosinophilic syndrome also I'll be giving a very similar picture, like eosinophils more than 1500 with multi-organ dysfunction and infiltration of eosinophils multiple organs, and no etiology can be found. All these things will be seen, but how will you differentiate between these two is what is very important for exams. At the same time, remember, imatinib is responsive to GIST tumors also. Imatinib is responsive to PDGFR rearrangements like CMML with eosinophilia and chronic chronic eosinophilic leukemia also, but it will not respond to this FGFR1 rearrangements, that is stem cell syndrome. So in the future, you might get a question, all of the following show imatinib responsiveness, except definitely they might give CML, they might give GIST, and they might give PDGFR rearrangements, and they will give FGFR1 rearrangements. So the answer for this question must be FGFR1 rearrangements, because that is the one thing that do not respond to imatinib. So I think we had a very good coverage on chronic myeloid leukemia and associated myeloproliferative neoplasms. So with this, I think we'll finish it off and we'll move on to the next section, which will be on myelodysplastic syndromes.